we are now starting our last lecture, which is on dying and bereavement. So first let's talk about the definitions of death. Well, this varies by culture. All cultures have their own view of death, as well as rituals that surround it. Think of some of the rituals you are familiar with. You're probably all familiar with the American funeral, but those of you who have different backgrounds may be familiar with different death rituals. So for some, we have funerals, or they see it as a passing. Some cultures revere past ancestors, like Asian cultures, okay? And just different cultures view death differently. The symbols a culture uses in death rituals provide insight into how they view it. Do they view it as final, as a transition? Is the person's life celebrated or mourned? So every culture has their own meaning that they put about death. So keep in mind that your views and rituals about death may not generalize to other cultures. So let's talk about the medical definition. Well, clinical death is the lack of heartbeat and respiration. However, some people can be brought back from this. So is it really death? So there's another definition called whole brain death. This is the most widely accepted. 8 criteria have to be met in order for this definition to be met. No spontaneous movement in response to stimuli. No spontaneous respiration for at least an hour. Total lack of responsiveness to painful stimuli. No eye movement, blinking, or pupil response. No postural activity, swallowing, yawning, or vocalizing. No motor reflexes. And a flat EEG for at least 10 minutes. Then all of this criteria has to be tested again 24 hours later. And if nothing has changed, then whole brain death is declared. This standard is used throughout the United States. Does this seem like too much to you? Having to test all of these things once and then again a day later? So why is it like this? This criteria can be difficult to meet in practice, especially the second assessment after 24 hours, because this could interfere with organ donation. So many professionals are calling for a simpler approach. This approach, the idea of the whole brain death, is also controversial in some religions. Another thing to consider is the persistent vegetative state. This is the situation in which cortical functioning ceases, but brain stem activity continues. That means the lower brain is still active, but the upper brain is not. The brain stem controls the heartbeat and respiration, but the cortex is all the higher processes. So somebody would still be breathing and have a heartbeat, but the higher functions of their brain are all absent. So whole brain death requires both areas to cease functioning, both parts of the brain, but what if the brainstem continues? Then this person is not technically dead, but people do not recover from persistent vegetative states. Their brain is gone. So what do? They're not legally dead, but are they alive? So this means that families and medical professionals have to decide what to do. So in conclusion, our definition of death still has a lot of gray area in it. No one really knows what is death and has a very clear definition of it. So there are some ethical issues. The field of bioethics is the study of the interface between human values and technological advances in health and life sciences. What do you do when machines are the only thing keeping someone alive? So this science, this bioethics, emphasizes the importance of individual choice and the minimization of harm over the maximization of good. So they weigh how much something will help against the suffering the treatment will cause. So they're trying to figure out, is the cure worse than the disease? So an example might be, should a cancer patient receive aggressive treatment that will be long and painful and probably not work? So does it do any good? Does it help the quality of life? Euthanasia, the practice of ending someone's life for reasons of mercy. For example, the persistent vegetative state or terminal illness. So ethically here, is there a difference between killing and letting die? Some people don't think there is. Some people think that letting someone die is the same as killing them, but other people view it differently. There are 2 ways to do euthanasia. The first is active euthanasia. This is the deliberate ending of someone's life. So this may be a drug overdose or a mercy killing. This usually involves situations of persistent vegetative state or the end stages of a terminal disease. So this is someone doing something to actively end someone's life. Passive euthanasia is just allowing a person to die by withholding their available treatment, like disconnecting the ventilator, withholding chemotherapy, don't perform a surgery, stop giving them food. This is passive euthanasia. You're just allowing nature to take its course. You're not intervening. So some ethicists and medical professionals don't distinguish between these two forms of euthanasia, saying that anything done to deliberately end a life is active. But most Americans favor acts such as removing life support in vegetative state cases or withholding treatment if a person agrees or is in the end stages of a terminal illness. Most Americans even support the idea of an assisted death, which means somebody helping the patient to die. However, feelings are also strong against these actions for religious or other reasons. Globally, these opinions vary, and it's often due to religion or politics. For example, Western Europeans tend to view euthanasia more positively than people in Eastern Europe or Islamic countries who tend to be more religious. So this is your big question. Do people have the right to die with dignity? Do individuals have the right to decide they want to avoid the suffering and or loss of function due to a terminal illness? How a culture views suicide attempts affects how people feel about the issue. So physician-assisted suicide. This is a process in which physicians provide dying patients with a fatal dose of medication that the patient self-administers. A poll in 2011 found that 70% of respondents agreed that people who are in great pain and have no chance of recovery should have the right to choose to end their own life. In 2012, 55% of respondents favored physician-assisted suicide for those who had less than 6 months to live. The Netherlands have legalized physician-assisted suicide as long as certain criteria are met. The patient has no hope of improvement, no relief is available, the patient is mentally competent, able to make their own decisions, the patient makes the request repeatedly, so it's not an impulse, and 2 physicians have reviewed the case and agreed to it. Several states have laws similar to this. Colorado just passed one, actually, last year, I think. U.S. laws allow people to obtain and use prescriptions for legal doses, but the physician has to inform the patient that he or she is terminally ill and describe alternative options, as well as meeting criteria listed above. However, some believe that doctors who do this are essentially murderers. So some hospitals opt out of these laws and don't allow their doctors to do it, and this is usually the religious hospitals. So even though the state law might allow for it, some hospitals don't allow for it. But as medical advances and technology increase, this issue is going to become more complex. So this issue needs to focus on quality of life, not length of life. With our advancing technology, do we do everything within our power just to increase the number of months somebody lives, even if they're in great pain throughout and there's no chance of them recovering at the end of it? Or do we just allow them to die on their own terms? This is a big ethical issue. So, personal aspects of death. The life course approach. Feelings about dying vary across adulthood. Most people don't give much thought to their own death until they lose their own parents. This usually happens around midlife. They realize that they are now the oldest generation in their family. So middle-aged adults shift their sense of time from the amount they've already lived to the amount that they have left. And this feeling increases with age. This may lead to a career change or other redirection. Remember we talked about midlife adjustments. This might be part of it. Or they might try to mend broken relationships. Older adults are less anxious about death and more accepting. And greater acceptance of death comes from achieving integrity, from Erickson's theory. So how do people deal with their own death? 2 approaches to describing the dying process, time between being diagnosed with a terminal illness and death. That's the dying process. So Kubler-Ross's theory, there are 5 reactions to dealing with death. You've probably heard these before. Denial, anger, bargaining, depression, and acceptance. This shows a typical range of emotional development, but not all people experience all 5 of those or go through them in the same rate or in the same order, and some people repeat them. You often hear these referred to as the stages of grief too, so this could be grief over your own impending death or grief over someone else. Stages should not be viewed as a sequence, just different states of coping. And people might move through these stages, like I said, in different orders, at different rates, and they may revisit previous stages at previous time or at different times. Second theory is the contextual theory. There is no right way to die, but there are better and worse ways of coping. So there are issues a dying person must face. The 4 dimensions are bodily needs, so they're physical needs. There's psychological security, there are interpersonal attachments, and spiritual energy and hope. So the coping efforts of friends, family, and caregivers also matter. So in this theory, the socio-environmental context must be recognized. For example, moving from home to a long-term care facility might change the ways in which a person copes with dying. So I want you to think about how different cultural views of death may change the way a person copes with it. That comes from the spiritual energy and hope. Would somebody who believes in heaven view their death in a different way who someone who doesn't? Or how about someone who believes in reincarnation? And so different beliefs may shape the way you view your own death. Death anxiety is a feeling of anxiety or even fear of death and dying. So terror management theory. This is a theory that addresses the issue of why people engage in certain behaviors to achieve particular psychological states based on deeply rooted concerns about their mortality. So the continuation of one's life is the primary motive underlying their behavior. So all your behavior could be linked to just trying to maintain your life for a little longer. Neuroimaging has shown that different parts of the brain are activated when thinking about death than when thinking about other types of pain or fear, like dental pain. So we have a different part of our brain that's used when we think about death than when we think about other pain. And people defend themselves against the emotions related to death. Some people block them off, don't think about them, or they have different ways of dealing with it. Some anxiety about death is normal, but we cannot allow it to affect our daily behavior. So death education is an increasingly popular way to decrease anxiety. So you give people factual information about death, you teach them the importance of advance directives, teach them how to be prepared, and these things can lower death anxiety in all age groups. When someone is facing their own impending death, these measures can help them deal with their anxiety. And we will continue this in the next video.